Hello. The task of the present lecture is infertility. What are the main issues that we will discuss at the present lecture? First of all, it's a definition and the epidemiology of the infertility, classification of infertility, causes of infertility, male infertility, female infertility, therapeutic options, and the role of the assisted reproductive technologies in the management of infertility. First of all, what is the infertility? Infertility is a failure of a couple to conceive after the year of having regular intercourse without the contraception. That means that if the couple have the regular sexual contact during the 1 year without any protection and there was no any episode of the pregnancy, then we should consider the infertility. And after that, we should start the examination of the couple to find out what is the exact reason for the infertility. What is the incidence of infertility? It is estimated that 15 to 18% of all pairs are infertile. And unfortunately, this number has an ability to increase all over the world. Why? Because it's related to the very high incidence of sexually transmitted infections that are the leading causes for the inflammatory disease of the female genitals and also male genitals. And these infections are really very serious affection to the quality of the sperm cells. Also, low socioeconomic status of some countries, as well as the low level of education, affect the increasing incidence of infertility. The incidence of female infertility is about 55 to 60%, and that means that the incidence of male infertility is about 40 to 45%. And as we see, the incidence of the male and the female infertility is almost the equal. What is the epidemiology of the infertility? Let's have a look to the map of the incidence of infertility all over the world. And if we have a look to this map, we will see that the regions that are in light purple, they indicate the level of infertility less than 9%. And we see the Northern America and South America, some parts of the North Africa, Arabic Peninsula, Australia, and some regions of the Northern Europe. The countries with the incidence of infertility 9 to 11%, they are indicated with the bright purple color, and these are mostly the countries of the Central Africa and most part of the Western Europe, some countries of Asia. In the most part of Africa, the incidence of infertility varies among 11 to 12.99%. And the maximum level of infertility, it's more than 13% we observe in the Eurasian continent and in some countries of Africa, also Oceania. What are the main causes for the infertility? 40% of all the infertile couples are presented by the male infertility. and the incidence of male infertility is about 40%. After that, equal amount of endometriosis and ovulatory processes or ovulatory problems that accounted each by 20% are responsible for the most part of the female infertility. 10% of female infertility is caused by unexplained factors and 10% by tuboperitoneal factor or blocked fallopian tubes. Let's have a look to the incidence of infertility by type and race. On this table, we see the main causes for infertility and the distribution of these causes among the different races and their incidence. In non-Hispanic white women, the maximal level belongs to the infertility, cases of infertility of unspecified origin. A little bit lower the other specified origin and minimal amount for the uterine origin. And we see in non-Hispanic Black women also unspecified origin, the maximal and accounted for 42.2%. Also Hispanic women, Asian, and other races. And we see that the most often the main cause of infertility is unexplained or it's a combination of different factors that lead to the development of the infertility. There are also some risk factors that predisposes to the development of the infertility. What are these risk factors? First of all, it's the age. The quality and quantity of a woman's egg begin to decline with increasing age. In the mid-30s, the rate of follicle loss speeds, resulting in fewer and purer quality egg. This makes conception more difficult and increases the risk of miscarriage. As we know, the incidence of miscarriages, spontaneous abortions, also chromosomal abnormalities is increasing with the woman's age. And we also always propose pregnant women at the age 35 to make genetic test for the presence of different chromosomal abnormalities. Why? Because of the process of aging, also biologic aging happens in the ovaries, and these seriously affect the quantity and the quality of the eggs. And with each age after 30 years old, this incidence has ability to increase. And that's why women at the age 40, for this woman, there is no chance, almost no chance for the conception. And in the protocols for assisted reproductive technologies, if woman is age 42 years old and older, we recommend the process of fertilization with the donor egg, because after the year 42, age 42 years old, there is a seriously damaged quality of the egg cell. Smoking. Besides damaging your cervix and the fallopian tube, smoking increases the risk of miscarriage and ectopic pregnancy. It's also thought to age ovaries and deplete eggs prematurely. And stop smoking before the beginning of the fertility treatment is necessary. And smoking is one of the most dangerous habits, and there is a recommendation for all the women, especially those who are trying to conceive or the pregnant woman, to stop smoking and avoid smoking at all. Weight. Being overweight or significantly underweight may affect normal ovulation. Getting to a healthy body mass index may increase the frequency of ovulation and likelihood of pregnancy. Both overweight or obesity and low weight that followed with a decreasing of body mass index below 18, they will follow with the problems with ovulation. And that's why, to keep the organism and the body with the normal body mass index that is equal to 19 till 24.9, it's the ideal body mass index for the conception. Sexual history. Sexually transmitted infections such as chlamydia and gonorrhea can damage the fallopian tubes. Having unprotected intercourse with multiple partners increase the risk of the sexually transmitted infections that may cause fertility problems in the later life. It is estimated that the sexually transmitted infections, especially intracellular obligates like as chlamydia, ureaplasma, and mycoplasma, they lead to the inflammatory processes of the upper genital organs such as fallopian tubes, and because of these infections, usually different degree of adhesions appear inside this organ, and the appearing and development of adhesions inside the fallopian tubes may lead to the different inflammatory processes. Also, it will make impossible the process of conception, or even the conception happens, it is impossible for the fertilized egg or zygote to move toward the uterine cavity, because the size of the zygote exceed the size of sperm cell for several fold times. Chlamydia is the silent pathogen, because very often people don't notice that they are contaminated with the chlamydia, because very often chlamydia has almost no clinical symptoms and is just characterized by the developing of the adhesions and inflammatory process, or a pelvic inflammatory disease, that are one of the main causes for the tuboperitoneal infertility. And of course, early onset of sexual life and the great amount of the sexual partners is increasing the incidence of sexually transmitted infection, and as the result, increase the incidence of infertility. Alcohol. It's the next risk factor, and stick to moderate alcohol consumption of no more than 1 alcoholic drink per day is the increase the incidence of infertility. Infertility classifies to primary and secondary. Primary infertility is considered when it occurs without any prior pregnancies. Secondary, when it follows the previous conception. For example, starting the sexual life and without any protection, and there is no episodes of pregnancy, no matter if this pregnancy terminated by the spontaneous abortion, miscarriages, recurrent abortions, or stillbirth, or the normal pregnancy, pregnancy term. Any episode with the pregnancy, it is estimated at the secondary infertility. But the primary infertility is considered when it occurs without any prior pregnancies. So there is no pregnancies at all. According to the World Health Organization data, there are 22 possible causes of female infertility and approximately 16 possible causes of male infertility. We will discuss it detailed lately. And let's start with the male infertility. The male infertility is one of the key problems of andrology. The incidence of male infertility is increasing and it is average 30 to 50%. Main causes of male infertility are genital tract infections such as prostatitis, mumps or orchitis, primary failure of testis function as a result of some chronic and chromosomal disease, trauma or surgery of male genitalia, occlusion of the venous ascendens ductus, exposure of the some medications, radiation, chemotherapy, alcohol abuse, excessive smoking, and psychological factors. As we see, there are so many factors that may lead to the development of the male infertility. And mostly we see that these are genital tract infections, chromosomal abnormalities, and childhood disease like mumps or orchitis, like mumps that may lead to the serious damage of the testes. Of course, one of the main causes for the male infertility is the varicocele or varicose dilatation of the venous vessels of the testes. And of course, some life habits or life habits, they also play a role of a risk factor that predispose to the developing of male infertility. What are the main causes for male infertility? It's a hypothalamic hypophyseal factor. It's a pituitary insufficiency or hyperprolactinemia, Kalman syndrome, hemochromatosis, pituitary tumors, and chronic illness that affect the hormonal secretion of the hypothalamus or of the pituitary gland. These are next group, it's the testicular disorders, different types of infections, Klinefelter syndrome, testicular atrophy, Y chromosome deletions, and systemic disorders. Seminal tract disorders, it's a retrograde ejaculation, obstructive azoospermia, some of immunological disease, especially autoimmunity to sperm, and psychosomatic disorders that may affect the process of ejaculation and may lead to erectile dysfunction. And it's become one of the causes for the male infertility. Somehow health and lifestyle and other habits, they may be also as the cause for the male infertility. Which of these lifestyle habits may lead to the infertility? First of all, it's a drug use. Anabolic steroids taken to stimulate muscle strength and growth can cause the testicles to shrink and sperm production to decrease. Use of cocaine or marijuana may temporarily reduce the number and quality of the sperm cell as well. Alcohol use. Drinking alcohol can lower testosterone levels, cause erectile dysfunction, and decrease sperm production. Liver disease, also caused by excessive drinking, also may lead to the fertility problems. So many problems related with the alcohol abuse. Tobacco smoking, again, the smoking is in the central role for the development of the male infertility as well as the female infertility. Men who smoke may have a lower sperm count than do those who don't smoke. Secondhand smoke also may affect male fertility. And weight, obesity can impair fertility in several ways, including directly impacting sperm themselves, as well as by causing hormone change that reduce male fertility. Obesity, it was proved that the incidence of infertility is much higher in obese men. And they have both the problems with the sperm quality, and they have problem with erection. They have erectile dysfunction. That is also one of the causes for the male infertility. When we make the examination of the couple, first of all, we should start with the examination of male, and we require for the spermogram or the semen analysis. And in this table, it was demonstrated the normal semen characteristics. As we see, the pH of the normal semen should be 7 to 8. Sperm concentration should be more than 20 million of sperm cells in 1 milliliter. Total number of spermatozoa should be more than 40 millions per ejaculate. Motility. In the semen analysis, there should be at least equal or more than 50% of sperm cell with progressive motility or 25% with rapid motility within 60 minutes after ejaculation. Morphology should be equal or more 14% of normal shape and form sperm, because in each ejaculate there should exist sperm cells of different normal and abnormal shape and forms, and that's why the normal morphology of the normal semen should be at least 14% the amount of the sperm cell of a normal shape. The number of leukocytes should not exceed 1 million per 1 milliliter. Immunobate test, there should be less than 50% spermatozoa with adherent particles, and excessive adhesion of the sperm cells to each others also leads to the infertility and is estimated one of the causes of immunological factor of infertility. And MAR test, less than 50% spermatozoa with adherent particles. What are the symptoms of the male infertility? The main signs of male infertility is the inability to conceive a child. There may be no other obvious signs or symptoms, but sometimes in some men, we can observe other symptoms. However, they are a manifestation of underlying problems such as inherited disorders or hormonal imbalance or dilated veins around the testicle, or a condition that blocks the passage of sperm and causes signs and symptoms. Signs and symptoms that are possible are the following. These are problems with sexual function, For example, difficulty with ejaculation or small volumes of fluid ejaculated, reduced sexual desire, or difficulty maintaining an erection, or we call this erectile dysfunction, pain, swelling, or a lump in the testicle area, recurrent respiratory infections, inability to smell, abnormal breast growth or gynecomastia. Usually we observe this condition in men with excessive body mass index or obese men because of the aromatization of androgens in the peripheric fat tissue into the estrogens, and these circulating free estrogens, they stimulate the breast proliferation and followed by the breast enlargement, and we call this condition gynecomastia. Decreased facial or body hair or other signs of a chromosomal or hormonal abnormality, and lower than a normal sperm count, fewer than 15 million sperm per milliliter of semen, or a total sperm count of less than 39 million per ejaculate. We know that the normal characteristic is 40, at least 40 million sperm cell per ejaculate. Let's discuss female infertility. What are the main causes for the female infertility? It is accounted for about 20% of causes of female infertility, and one of the main causes is the tubal peritoneal factor. Tubal peritoneal factor of infertility occupies first place in the structure of etiological causes, and its incidence is about 40–60% of all female infertility cases. Main causes of tubal peritoneal infertility are infections of the genital tract. Most commonly, it's gonorrhea, chlamydia, ureaplasma, mycoplasma, tuberculosis, genital herpes, formation of the adhesions as a result of medical interventions and complications of surgical operations, and also endometriosis. All the conditions that lead to the development of adhesions in the cavity of the fallopian tubes or outside in the pelvic cavity, and that lead to the development of adhesions that make the deformation of the fallopian tubes, are the causes for the tubal peritoneal factor. How we find out, how we make the diagnosis of this condition? The most common method for the examination is a hysterosalpingography. What does it mean? It's a method of examination very popular in gynecology, and it's based on the administration of the special contrast dye into the uterine cavity by the special pump, and when this dye fulfills the uterine cavity, it flows through the fallopian tubes, fulfilling the tubal cavity, and after that, it goes into the abdominal cavity. And in this picture, we can see that the dye fulfilled the uterine cavity and its flow through the left fallopian tube and into the abdominal cavity, but we cannot see the right fallopian tube. What does it mean? It means that the fallopian tube is closed. There is no possibility for dye to flow through the right fallopian tube. And it's the most common and the simple method of examination of the tubal transport. And we administer this solution inside the uterine cavity and make the series of X-ray imaging and find out the exact reason. Usually hysteroscopy is indicated for those women with suspicion to the tuboperitoneal factor to find out are the tubal cavities are able to, they are open. And usually we perform hysteroscopy during the first phase of the menstrual cycle at the days of 8 to 12. And the efficiency of this method as a diagnostic value of this method is about 70%. One of the main causes for the tubal peritoneal infertility is the external genital endometriosis. What's the endometriosis? Endometriosis is the chronic progressing disease that characterizes by the developing of the endometrial tissue outside the uterine cavity. And there are different theories that try to prove the origin of endometriosis, but we don't know exactly what predisposes for the development of endometriosis, but we know that the endometriosis is the chronic and progressive disease. And there are two different types of endometriosis, and external genital endometriosis is one of the causes for the tubal peritoneal infertility. In these pictures, we clearly see the different shaped and sized these lesions, endometriotic lesions, that lead to the deformation of the genital organs. And depending on the amount of these lesions and the degree of invasion of these lesions, the severity of the disease also varies. The method for the diagnosis of this external genital endometriosis is the diagnostic laparoscopy. Next is the ovulatory factor. What is this? There are two types of ovulatory disorders. Anovulation, in which eggs do not develop properly or are not released from the follicle of the ovaries, and oligoovulation, in which ovulation doesn't occur on a regular basis and usually is found in women with length of the menstrual cycle 35 days and more. And let's have a look which conditions, which disease may lead to the ovulatory problems. First of all, it's a polycystic ovary syndrome. Polycystic ovary syndrome causes a hormone imbalance which affects ovulation. Polycystic ovary syndrome is associated with insulin resistance and obesity, abnormal hair growth on the face or body, and acne. It's the most common cause of female infertility. The etiological factor of polycystic ovary syndrome is also unknown, and this is the systemic disorder, and it's a chronic disorder, and unfortunately it cannot be totally treated for the moment. We only have the palliative therapeutic or symptomatic treatment or options, and the polycystic ovary syndrome is followed by the hormonal imbalance in all the body and predisposes to the failure in ovulation because due to this hormonal imbalance, the ovaries covered by the fibrotic capsula, and this capsule doesn't give possibility for the follicles to develop and to rupture, and that's why there is a low chance for the ovulation. Hypothalamic dysfunction. Two hormones produced by the pituitary gland are responsible for stimulating ovulation each month. These are follicle-stimulating hormone and luteinized hormone. Excess physical or emotional stress, a very high or very low body weight, or a recent substantial weight gain or loss can disrupt production of these hormones and affect ovulation. Irregular or absent periods are the most common signs of the failure of hypothalamic function. Premature ovarian failure, also called primary ovarian insufficiency. This disorder is usually caused by an autoimmune response or by premature loss of eggs from the ovary. It's maybe there is a possibility of this disorder to be genetics or as a result of different types of exposure or chemotherapy. The ovary no longer produces egg, and it lowers estrogen production in women under the age of 40. And the excessive amount or production of prolactin when the pituitary gland may cause excess production of prolactin or hyperprolactinemia, which reduces estrogen production and may cause infertility. Usually related to a pituitary gland problem, this can also be caused by the medications taken for another disease, and which disease usually these are different types of psychological problems and depressions, anxiety, or more severe psychological problem that require the intake of different medicines and drugs, especially dopamine agonists, and they lead to the we know that the dopamine is the antagonist of the or inhibitor of prolactin, and when there is the increase in the level a decrease in the level of dopamine, we observe increased level of prolactin. Also, we observe increased levels of prolactin at the in case if there are the tumors of the pituitary gland, like a microadenoma or microadenoma, and these tumors they produces excessive amount of prolactin, and prolactin suppress the ovulation, and that's why women with hyperprolactinemia they have the problems with ovulation. Other causes for female infertility are congenital abnormalities of genitalia or abnormal structure of the uterus or fallopian tube, such as uterus didelphus or bicornuate, unicornuate uterus, or the uterus that undergoes agenesia or aplasia, or a saddle-like uterus or uterus with the septum inside. It's aplasia of the vagina, or Rokitansky-Kuster-Meyer syndrome. It's a syndrome with the aplasia of the upper genital organs with the normal development of the ovaries, and that's why secondary sexual characteristics are exist in the absence of the menarche and menstruation. Also some chromosomal abnormalities, pathology of the cervix, immunological incompatibility, psychological disorders, usually they followed by the vaginism and absence of ability of women for the sexual contact, She's just afraid of the sexual contact. Idiopathic type of infertility, endocrine disorders, and other gynecological problems. What are the diagnostic procedures for the diagnosis of infertility? Diagnostic procedures, they require simultaneous examination of both partners, and that's why when the couple come to the hospital and they have the first visit to the physician, first of all that we should do is check the partner for the quality of sperm. We require for spermogram. After that, everything is okay. We start the examination of the woman. Usually, we start do it at the same time. First of all, we obtain the detailed medical anamnesis and lifestyle habits. It's menstrual problems. We ask for the time of the menarche. We ask about the menstrual cycle. Is it regular or irregular? The duration of menstrual cycle, any problems with menstrual cycle that's like a polymenorrhea, oligomenorrhea, hypo or hypomenorrhea, and amenorrhea. Administration of contraceptives. History of spontaneous abortions. To check if there is some infectious disease or congenital abnormalities of the female genital organs, sexually transmitted infections, use of lubricants, because lubricants, they inactivate the sperm cells, erectile dysfunction, diabetes mellitus, smoking, alcohol abuse, poor physical activity or excessive physical load, history of weight fluctuation, and the chronic stress. We should ask about all these parameters to find out the exact picture and make the plan what to do in the next stages. What is the basic evaluation of infertile men? First of all, we start with the history. We obtain full anamnesis, physical examination performed. After that, we require for semen analysis and normal hormonal profile. We check for the level of the hormones in the blood serum. Also, we treat female factor if the such is exist. We make the evaluation of female. If there is everything normal, then we consider the unexplained male infertility. If so, then we make the expectant management wait period for 1 or 2 years. If the woman is aged less than 35 and duration of infertility is less than 3 years. If the unexplained male infertility and it's in the active phase, we make the examination of the sperm cervical fluid penetration. We ask for the postcoital TAS and the sperm function of the testis. Parallel, we make the shaking motility of sperm motility. We make the determination of the anti-sperm antibody bodies, and if they exist, we make the diagnosis of immune infertility, and after that treatment by the steroid therapy, or if it doesn't help, we transfer this patient to the reproductive center for the Artificial Reproductive Technologies Administration. If the sperm function test low, what we do? We make the assessment or fertilization potential. Sperm zone pellucida binding, completeness of capacitation, hyperactivation assessment and acrosomic reaction, and zone-free hamster egg penetration assay. If there exist, and this couple is transferred for the ICSI. ICSI is the intracytoplasmatic sperm injection. This is part of artificial reproductive technologies. What are the main protocols that we use in the diagnosis of the infertility? First of all, there are several protocols that's proposed with different organizations, but we use the main protocols that proposed by the First Royal College of Obstetricians and Gynecologists, American Society of Reproductive Medicine, European Society of the Human Reproduction and Embryology. The primary investigation include transvaginal ultrasound examination, detection of anti-Mullerian hormone. This demonstrates the reserve of the follicles. We check for the level of hormones in the blood serum. It's follicle stimulating hormone, luteinized hormone, thyrotropic hormone, prolactin, estradiol, and inhibin B. Of course, semen analysis, follicle tracing, anatomical defects, presence of congenital abnormalities, myoma, polyps, and Asherman syndrome. What is the Asherman syndrome? It's a syndrome, pathological condition that following with the development of adhesions inside the uterine cavity as a result of excessive curettage and damaging of the basal layer of endometrium, basal cells of endometrium, with the developing of adhesion between the walls of the uterus. Polycystic ovarian syndrome and presence of endometriosis. For this purpose, we perform the diagnostic laparoscopy. What purposes we use diagnostic laparoscopy and when we perform hysteroscopy? Laparoscopy we perform in case when there is the abnormalities of the uterine structure, congenital abnormalities, or in case when there's a myoma of the uterus, pathology of the fallopian tubes, such as occlusion or hydrosalpinx, pathology of the ovaries, such as polycystic ovary syndrome and endometriosis, and pelvic organs in the presence of endometriosis and adhesions as a result of pelvic inflammatory disease. Hysteroscopy we perform for the diagnosis of the polyp, and parallel with it we perform polypectomy if the polyp exists in the uterine cavity. To find out if there are adhesions inside the uterine cavity, and parallel we perform adhesion lysis. Removal of the submucous myoma and myomectomy, because submucous myoma, they leads to the deformation of the uterine cavity and followed by the excessive bleeding during the menstrual cycle or between menstrual cycles, like metrorrhagia, and also in some cases they made the obstacle for the implantation of fertilized egg. That's why it's very important to remove the submucous myoma before the planned conception. Septate uterus and the resection of the septum. Usually we perform hysteroscopy and use the special instrument hysteroresectoscope for the performing of these therapeutic procedures. In case of male infertility, we use the obtain the medical therapy. We use make the administration of the different drugs, medicines, or we perform the medical therapy. Usually, we use anti-estrogens, androgens, bromkriptine, antioxidant, alpha blockers, and mast cell blockers, systemic corticosteroid, or antispermic antibodies treatment. We use this medical therapy in case when there are underlying disease, and these are therapeutic options for the removing of the symptoms, cessation of the symptoms of this underlying disease. Also, we perform surgical interventions such as varicocele. We remove the vessels, veins that are enlarged and dilated. The most effective treatment method for moderate and severe semen pathology are IVF and ICSI. What is the IVF and what is the ICSI? These are two types of artificial assisted reproductive technologies, and assisted reproductive technology, they includes the following methods. First of all, it's in vitro fertilization and embryo transfer. What does it mean? It means that we obtain, first of all, we make the stimulation of ovulation and obtain the different number of follicles when they are become mature, and we also take a sperm, and after the special cleaning of the sperm and obtaining of the follicle, we make the fertilization outside the uterine cavity in the special glass plate under the control of microscope, and the embryos develop as a result of this in vitro fertilization. After that, we make the transfer of embryos into the womb at the day 3 to 5 of the embryonal development, and it's recommended to make transfer of the single embryo, but it's also by the protocol, but it depends on the exact situation. Gamete intrafallopian transfer or gift, when we make the transfer of the gamete inside the fallopian tube to imitate the normal process of fertilization, but this method doesn't prove itself. Zygote intrafallopian transfer, when we perform in vitro fertilization and make the implantation of a zygote inside the fallopian tube and resemble the normal pathway of the zygote into the uterine cavity. ICSI, it's intracytoplasmatic sperm injection. Usually we recommend this method to couples with severe male infertility when they're very poor semen quality. And we make the injection of the single sperm cell into the cytoplasm of the egg. And frozen embryo transfer, it's a transfer of the frozen embryos that we keep in the special condition of the very low temperature, about minus 196 degrees by Celsius. And when we perform in vitro fertilization, we obtain several embryos, and as we transfer only one or maximum two embryos inside the uterine cavity, a recent amount of the normal healthy embryos we just freeze in these special refrigerators, and in case or unsatisfied embryo transferred and the failure of the conception or the pregnancy, when we can use these frozen embryos. And it is estimated that the pregnancy with the frozen embryos is more effective than with the fresh embryos. Also, there are some protocols for the couples depending on the years. In 20 to 30 years, with the normal semen analysis, the recommendation is the ovulation control during 2 to 3 menstrual cycles and folliculometry. Also, we perform diagnostic laparoscopy, hence, and hysteroscopy for cycles of intrauterine insemination and clomiphene plus menopausal human gonadotropin stimulation of ovulation. And the last stage is the IVF plus ICSI, depending on exact situation. If the woman is at age 30 to 35 years, also partner has the normal semen. When our recommendation, we check for anti-Mullin hormone and antral follicle count. If anti-Mullin hormone more than 2 and antral follicle count more than 5, then we perform diagnostic laparoscopy and hysteroscopy, clomiphene citrate for the stimulation of ovulation, and IVF. If anti-Mullin hormone less than 2, antral follicle count less than 5, then we recommend IVF plus ICSI. If woman is at age 35 to 40 years and with the normal sperm analysis and the duration of infertility more than 5 years, we check for anti-Mullin hormone. If it's more than 2 and antral follicle count normal, we recommend IVF with self-XL. If anti-Mullin hormone is 1 to 2 and very low count of antral follicles, we recommend IVF with self-XL or donor egg. And if anti-Mullin hormone less than 1 and again low level of antral follicle count, then we recommend IVF with donor egg. If woman is at age 40 to 45 years, we recommend IVF or ICSI. In 20% of cases, only possible the self-XL before the age of 42 years old, and in 80% of cases, we recommend donor XL. What are the main indications for IVF? It's a bilateral tubal occlusion. There is no possibility for the treatment and make the removal of these adhesions when we recommend IVF. Severe oligoastenospermia or azoospermia, it's absence of the normal sperm cells in the ejaculate. Premature ovarian failure with a very low indicators of anti-Mullin hormone and very low antral follicle count. Age of woman more than 40 years old, and the presence of genetic disorders. And at the end of our lecture, I want to tell you very good words. God always answers in 3 ways. He says yes and gives you what you want. He says no and gives you more. And he says wait and give you the best. Thank you for your attention.